Congenital adrenal hyperplasia due to steroid 21-hydroxylase deficiency, an Endocrine Society * clinical practice guideline. Congenital adrenal hyperplasia. A number of autosomally inherited enzyme deficiencies result in cortisol deficiency, excess pituitary ACTH secretion, and adrenal gland hyperplasia. 21-hydroxylase deficiency, greater than 90%. The most common cause of CAH results in cortisol and MC deficiency, while the buildup of precursor steroids is channeled into excess adrenal androgen synthesis. Different defects in the 21-hydroxylase gene, e.g. deletion, splice site or point mutation, result in different degrees of enzyme deficiency, and thus a wide variation in phenotypes.
1,1-beta-hydroxylase deficiency, 5%. This enzyme converts 11-deoxycortisol to cortisol and is the final step in cortisol synthesis. In addition to excess adrenal androgens, the overproduced precursor corticosterone has MC activity. Thus, in contrast to salt wasting in 21-hydroxylase deficiency, affected individuals may have hypernatremia and hypokalemia. Hypertension is rare in infancy but may develop during childhood and affects 50 to 60% of adults.
1,7-alpha-hydroxylase deficiency impairs cortisol, androgen, and estrogen synthesis, but overproduction of MCs leads to hypokalemia and hypertension. 3-beta-hydroxysteroid dehydrogenase deficiency impairs cortisol, MC, and androgen biosynthesis. Males have hypospadias and undescended testes. However, excess DHEA, a weak androgen, may cause mild virilization in females. Steroid acute regulatory protein STAR mutation, 46XY sex reversal and severe adrenal failure. Heterozygous defects extremely rare. CPI, P450, side chain cleavage cytochrome enzyme 46XY sex reversal and severe adrenal failure. Heterozygous defects extremely rare. P450 oxidoreductase deficiency. Biochemical picture of combined 21-hydroxylase/17-alpha-hydroxylase/17-20 deficiencies. Wide spectrum of presentation from ambiguous genitalia, adrenal failure, and antly. Bixler skeletal dysplasia, complex craniosynostosis, syndrome through to mildly affected individuals with PCOS. Clinical features. Virilization of female fetuses may result in clitoromegaly and labial fusion at birth. 75% have mineralocorticoid deficiency resulting in renal salt wasting. Because males have normal genitalia at birth, they may present acutely ill in the neonatal period with vomiting, dehydration, collapse, hyponatremia, and hyperkalemia. Non-salt wasting boys present in childhood with early genital enlargement, pubarch, and rapid growth. If untreated or poorly treated, both sexes may develop pubic hair, acne, rapid height velocity, advanced bone maturation, and precocious puberty, which may result in very short adult height. Non-classical CAH is due to milder 21-hydroxylase deficiencies. Affected girls present in childhood or adulthood with hirsutism, acne. Premature/exaggerated adrenarche, menstrual irregularities, and/or infertility.
Specific investigations for CAH. Plasma 1,7-OP. An elevated level indicates 21-hydroxylase deficiency. It may be difficult to distinguish this from the physiological hormonal surge which occurs in the first 2 days of life. This test should therefore be repeated, together with 11-deoxycortisol, after 48 hours of age. 24H urine steroid profile, also collected after 48 hours of age, to confirm the diagnosis and to detect rarer enzyme defects. Synacthin registered stimulation test may be required to discriminate between enzyme deficiencies. Plasma and urine electrolytes should be regularly monitored during the first 2 weeks of life. Plasma renin level to assess salt wasting in those with normal serum Na and relatively mild 21-hydroxylase deficiency. Newborn screening. ES recommends that all newborn screening programs incorporate screening for congenital adrenal hyperplasia due to 21-hydroxylase deficiency. We recommend that first-tier screens use 17-hydroxyprogesterone assays standardized to a common technology with norms stratified by gestational age. Technical remark: clinicians should be aware that immunoassays are still in use and remain a source of false positive results. Specificity may be improved with organic extraction to remove cross-reacting substances.
We recommend that screening laboratories employ a second-tier screen by liquid chromatography, tandem mass spectrometry in preference to all other methods, example, genotyping, to improve the positive predictive value of congenital adrenal hyperplasia screening. Technical remark: laboratories utilizing liquid chromatography, tandem mass spectrometry should participate in an appropriate quality assurance program. Additionally, clinicians should realize that immunoassays lead to more false positive results. Thus, if laboratory resources do not include liquid chromatography, tandem mass spectrometry, a concentropin stimulation test should be performed to confirm diagnosis prior to initiation of corticosteroid treatment.